So hi everyone, I'd like to welcome Dr. Ian Harris, Professor Dr. Ian Harris, to the Pain Universe, and maybe you can start off by introducing yourself.
Yeah, so my name's Ian Harris. I'm an orthopaedic surgeon from Sydney in Australia. I've been a practicing orthopaedic surgeon for 25 years nearly, but I'm also an academic, and I do a lot of clinical research into the effectiveness of surgery.
All right, thank you. And how old are you and where are you from? Did you mention that?
Yeah, from Sydney in Australia. Yeah.
Where were you born?
In Sydney. I grew
Also
up in Sydney.
Yeah.
I trained in Sydney.
All right.
Yeah.
A Sydney man.
Yeah. I did a bit of training in the US, and I was in Germany for a little while, but basically in Sydney my whole life.
Okay,
yeah.
cool.
Yeah.
So my very first question is going to jump right into the hot ones and ask you, is there any good evidence for the use of surgery for any problem as far as you are familiar?
Yeah, I think surgery is probably very effective for obvious mechanical things. And the problem with surgery is when it gets used for more subjective, poorly described things like pain, for instance. So if you looked at, cataract surgery for loss of vision, I think there's fairly good evidence that it improves vision. If you look at some of the surgery that I personally do, if I have somebody with a leg that is too short and turned out to the side, if I operate on them and correct the deformity and realign it, I don't have randomized controlled trial evidence, but I think there's fairly good evidence that the leg is straight again after I do it. This is the kind of simple, mechanistic, objective kind of surgery that appeals to people and makes them want to do surgery, is that kind of thing. But what ends up happening is that most surgery, though, is not done for things like that. That's uncommon. And in orthopedic surgery, musculoskeletal surgery, it's often done for pain, and even when it's not done for pain, sometimes it's not so clear, because if it's done for things that will get better anyway,
then the surgery will work.
Then the surgery appears to work.
Yeah, appears to work.
Yeah. So my area of expertise is trauma surgery in fractures, and in a lot of that, we operate unnecessarily because fractures heal anyway. So there's a lot of areas of controversy where there's practice variation, where some surgeons say we shouldn't be operating and other surgeons operate quite aggressively.
So what's the best evidence for surgery for a pain problem? Do you know of any condition or any back pain or knee pain or that you are familiar with? What evidence is out there that says for this condition it seems that surgery is a good option?
Yeah, so I'd say one of the most common procedures in musculoskeletal surgery for pain would be, for example, total hip replacement for pain and stiffness from osteoarthritis, because often people complain that they can't bend over, they can't reach their toes, they have difficulty moving it, but largely it's done because of pain in the hip with movement. But that has not been subjected to a randomized control trial, comparing it, certainly not to placebo surgery, but even comparing it to best non-operative treatment, there hasn't been a trial. So while we believe this surgery to be effective in relieving pain, and it probably is, we don't know how effective it is, and we don't know at what threshold we should be doing the surgery.
Or why it works.
This is a really good question, is how it works. Knee replacement is another example. So we believe that knee replacement helps the pain of knee osteoarthritis, and yet sometimes we don't replace all of the knee. We don't replace the kneecap, which may have arthritis in it, and yet it still works. That doesn't make any sense to me at all. The other example with hip osteoarthritis, it's very appealing, it makes a lot of sense. In the old days, before total hip replacements, often they would do a half a hip replacement and just replace the ball and leave the arthritic cup, and it worked very well. So that, again, doesn't make sense. I don't know where the pain's coming from.
It begs some questions, at least. about the mechanisms behind why there's a pain reduction and possibly an improved function.
Yeah,
interesting.
Because I think when you do this surgery, certainly hip replacement surgery increases the range of motion that you get, and probably decreases the stiffness. Knee replacement surgery often takes a crooked, unstable knee and makes it straight and stable, and maybe a lot of that makes people feel better. It's the stability and the realignment and the freedom of movement that makes them feel better.
Yeah,
and maybe that sensation of feeling better about your knee or your hip makes you think that the pain is better.
Yeah,
I don't know. It's very complicated.
It is very complex, because I would imagine that if you have your knees realigned or knee realigned, there's pain afterwards for sure.
Yeah, from the surgery, yeah.
Yeah, from the surgery. But now the knee is right and you feel safe and pain is normal after surgery, and you start to rehabilitate believing, my knee is good now.
Yeah.
And then perhaps pain disappears and
perhaps
and
the pain the same as it was before, but you just feel better about it.
Exactly,
more accepting
so.
of it, yeah.
So perhaps, we need to exclude that. It could be the belief that, the knee is okay now, or from the surgery, so we can see what is the real effect of the surgery.
Yeah.
But that's not been done yet.
No.
Interesting. You also talk about osteoarthritis, and just so I'm not confused, because to me, osteoarthritis currently means a lot of different things. Are you talking about radiographic osteoarthritis, or the clinical diagnosis of osteoarthritis, which is based on subjective measures from...
Normally in orthopedic surgery we talk about radiographic arthritis.
So it's the radiographic.
So normally by the time somebody needs a knee or hip replacement, they have significant loss of joint space and all the other radiographic characteristics of osteoarthritis. But that still has to match the patient's symptoms. I mean, we often get patients with severe symptoms but not much radiology, and sometimes, surprisingly commonly, I see people with quite severe radiographic findings who are still coping very well, and their pain is not that bad, and they don't need surgery.
And what if we did MRI on the asymptomatic population, so the people that doesn't have pain, and the older population? Do you think we'd find severe osteoarthritis there as well? Or?
Yeah, for sure.
But they are asymptomatic. They don't have any pain.
Yeah.
So that also leaves us with some questions, right?
Oh, sure does, yeah. Questions that I can't answer. But it reminds me, many years ago, my grandmother, who was very old, was admitted to hospital after a fall. And she had an x-ray of her pelvis to see that she didn't have a fracture.
Yeah.
And she didn't have a fracture and she was okay. But I remember as a young doctor at that time looking at the x-ray, and she had terrible arthritis, like the worst arthritis I'd ever seen. But it was never a problem to her, yeah. Yeah,
so from my current understanding, from radiographic osteoarthritis and pain, the correlation is actually quite weak. You can have a lot of osteoarthritis and no pain, or a little pain. You can also have a lot of pain. Yeah. You can have very little and a lot pain, little pain and no pain. It just seemed that the relationship is a bit shady. There's a lot of uncertainty in this area.
There is.
And it would be perhaps an overreach to talk about causal relationship with pain. So I find it very likely that it can contribute, but saying that this is the main risk factor for why you have pain, at least in my understanding of the literature, is a bit of an overreach.
Yeah, no, I agree. And even some surgeons I know, so very experienced surgeons and thoughtful surgeons, have this problem, and they tend to not operate so much for pain. For knee osteoarthritis, and they'll be very selective with who they operate on. And it's the patients who have, perhaps, deformity and instability and functional problems, and they're much more comfortable operating on those patients because they know that they can correct those problems.
So they're looking at at dysfunction or disability and saying, if I correct these mechanical issues, there's an increased likelihood that you'll improve function.
Yeah, yeah.
Oh, interesting.
Yeah, because they're the two reasons we operate is pain and function, functional loss and pain. And so, some surgeons they feel that this concept of pain is unreliable and they can't predict very well that they will improve the patient's pain by surgery.
But there's a recent study on that, actually.
Right.
I think it was on meniscus tears,
if
I believe correctly.
Yeah.
And they were like, can you predict who will benefit?
I was involved in that study.
Oh, you were involved?
Yeah,
oh, sorry, I didn't know.
No, they came from Denmark. And what they did is we surveyed surgeons in Denmark and Australia.
Yeah.
And we gave them clinical scenarios and said, this patient's got this meniscus tear with this age and this findings. Do you think they'll get better with surgery or non-operative treatment? The surgeons had no idea which ones would get better and which ones wouldn't. Yeah. It's very difficult to predict.
It's so interesting. There's a lot of uncertainty in the area.
Yeah.
A lot of things we don't know yet. So that's good that we have research to try help us out and make more informed decisions.
Yeah.
So you wrote a book called Surgery, the Ultimate Placebo.
Yeah.
Why did you write that book? What was the drive?
That's a very good question. I wrote it because of to try to reset what I thought was a complete sort of bias in the community, not just the surgical community, but society at large, about the perception of surgery.
And what is the perception of surgery?
The perception of surgery is that it works. People are often very suspicious of medical therapies. People understand that maybe things like antidepressants might not be that effective, and maybe they have a placebo effect. But when it came to surgery, there's never any question. Surgery works. Yeah. Otherwise, we wouldn't do it. And it has this sort of mechanistic appeal of cutting things out, and it's very simplistic.
Finding the flaw and removing the flaw.
Right? That's right. And I started practice as a surgeon, believing that, and I had no good science training or clinical, critical evaluation skills, kind of skills. But when I got those, and I started reading these papers and understanding things a little bit better. I realised, of course, the first thing they teach you is that a lot of medicine that we do doesn't work and the evidence isn't very good, and I thought that was really interesting. But then I started applying that to surgery, and I thought, hang on a minute, the evidence for surgery is even worse than some of these things we're doing in medicine. And when you look into it, a lot of it doesn't work. And it's very complicated, but it boils down to these unfounded beliefs that surgeons have. Surgeons are more likely to believe what other surgeons tell them. They're more likely to believe in the fallacy that if patients get better after they operate on them, they got better because they operated on them, and they don't recognise that as a logical fallacy.
Post hoc, ergo propter hoc.
Exactly. Post hoc, ergo propter hoc.
Yeah. It's thereafter, therefore.
Therefore, because of. And so I try to get this message out, and that's one reason I wrote the book, was to appeal to everybody. I spent a lot of time lecturing to surgeons and trying to do studies with surgeons and challenging surgeons' beliefs about their effectiveness. But I wanted to reach a broader audience, like the general public. And so I thought the best way of doing that is I actually wrote a blog, because somebody said to me many years ago, they said, you should write a blog, and that way people can read it and you can get the message out. So I wrote the blog, and the blog was successful and had a lot of followers. But really the book was almost like a compilation of the blog stitched together in book form. Interesting. That's made it easier to write.
I really enjoyed your book, and I think that was the first time I was introduced to the knowledge that you can actually do surgery without any ethical approval, and you can start doing it. And I'll do my surgery today on your leg, and I'll call it the Simon method. And I'm doing it, and you get better. and of course, I believe you get better because, you know, I did the surgery. It can't be time or coincidence or any other factor. It must be my surgical intervention. But in order to actually investigate, does this surgical intervention really work? Then you need ethical approval. Yeah. And I found that very...
This is the ethical paradox.
Frightening, sorry.
Yeah, that's the ethical paradox, is that you don't need ethical approval to uncontrollably experiment on people, but you need ethical approval if you're going to do a controlled experiment on somebody. And another quote in this regard was... somebody once said, I don't need ethical approval to experiment on all of my patients, but I do need ethical approval to experiment on some of them. It doesn't make any sense. It's a paradox. But it happens. I was at a meeting recently debating surgery for tennis elbow, for epicondylitis. And I gave the case that surgery is not effective. And in fact, there has been one small placebo surgery study done showing that it was no more effective than placebo. But one surgeon in the audience got up and he said, you know, the reason that surgery doesn't work is because they did it wrong. He says, I've developed a procedure, which I do, which involves a certain kind of way of cutting tendons. I don't know exactly what it was. He explained it. And he said it works, you know, every time. And that's what, you know, why those studies didn't work is because they're not using my technique, which I use widely. And I just on the spot, I didn't really know how to respond to that. So I just said to him, I said, so do you think that you know the cure for tennis elbow? You have the cure. No one else has it. You have the cure for tennis elbow. And he was like, oh, no. But that's what you're telling me. You're telling me you have a procedure that cures tennis elbow. And he backed down. But I said, why are you backing down? You should be celebrating this.
Of course.
And he got very defensive. And of course, I explained to him, and this is for your audience as well, is that studies show that in 12 months, 97% of people with tennis elbow will be better.
Except if you get a cortical injection or steroid injection, you're actually going to be...
It may prolong.
You're going to prolong it. So cortical injection works worse than if you just let time pass.
And after that, I developed tennis elbow myself.
Oh, really?
And it was quite bad.
Did you seek out that surgeon?
No, I certainly did not seek out that surgeon. But a friend of mine was doing a trial, and it was comparing a placebo injection to steroid, to platelet-rich plasma. So a 3-arm study. And so I went into that study, and the injection did nothing immediately, but after 9 months, it got better. You know. and
I think it's the injection. What else could it be? It can't be anything else.
I don't know what group I was in yet. No. The study is still ongoing, but I want to find out. And I'm hoping I was in the placebo group, so I can say that I got better from placebo. I
think actually, if you look at injections, I think you're actually better off with 3 to 6 months, but I can't remember right now. So I hope that the placebo group got better within 3 to 6 months.
Earlier.
Earlier. And then you were in one of the interventions group not showing, but that's my bias.
I think there won't be much difference because tennis elbow just gets better.
It does. Yeah. So now we're talking about surgery. What studies out there that shows that sometimes we've been too aggressive and relying too early on what we see works? I mean, is there surgical interventions out there that we've been using for a long time that when we test it and compare it to sham surgery, that you know the person believes he or she had surgery but didn't really have surgery? Yeah. And then it proved there was no real effect from there.
Yeah, so the very first example of that was published in 1959, which was a surgery to ligate the internal mammary artery for angina.
Yeah,
and that was done in the 40s and 50s. And 1959, they published a placebo study where they tied off the artery in half. And in the other half, it was a very good placebo study because what they did is they made the incision, they also put the suture, put the ligature around the artery. They did everything but did not tie the knot. And they found no difference between the two groups. It was a long time before the next one, but there was a study on Parkinson's disease in 2001. And then in the 2000s, in the last 20 years, there's been more and more placebo surgery studies, and there's several now underway, and it's becoming more common. But in my area of musculoskeletal surgery, there's been several on knee surgery and shoulder surgery in the last 10 years or so, all of which have shown no benefit over placebo.
Or sham, yeah.
And these are procedures. The knee arthroscopy is the most common orthopedic procedure in the world. Shoulder arthroscopy is the most common shoulder procedure in the world. And these are not rare procedures. These are everyday procedures. And that, look, it is having some impact on practice, but it hasn't been an overnight change, that's for sure.
So these surgical studies where you compare with sham actually test, I'm doing the real surgery now, and I'm pretending to do the real surgery now. You get the surgical incisions, but that's all you get. Maybe you get some saline water shot into it, but that's it. And afterwards, both group gets better.
Yeah.
But they get equally better.
Yeah, and that's an important point, because it's not as if when people think that the surgery doesn't work, they think, oh, nobody got better afterwards. So that's not the case.
No, they actually do get
and in
better,
fact, 2/3 roughly of the patients will get better after surgery and after placebo. But mistakenly, people attribute that to the placebo effect. They say, oh, that's all due to the placebo effect, and it's not. It's largely the fact that these conditions fluctuate and they would get better anyway. That's underappreciated. Because when you attribute it to the placebo effect, then surgeons still do the surgery. And
but placebo effect is also real or really strong, or
exactly. I'm doing it for the placebo effect, which is wrong.
Everything else failed, so they have no more options than me.
This is a really strong driver of surgery, is this two things to unpack there. One is failure of non-operative treatment, and the other one is the lack of alternatives. And many surgeons argue to me, well, I have to do a knee arthroscopy because they've failed non-operative treatment, therefore they need operative treatment.
Yeah.
And superficially that sounds logical.
Yeah.
Oh, they've failed non-operative, so they need operative.
Yeah.
But logically it's false, because if you have a surgical procedure that doesn't work, the failure of another treatment doesn't make it work. It still doesn't work.
Yeah.
So you've got to think of it differently. But the other thing that is very difficult for surgeons is, what else can I offer them? So if there was a pill that we could take that worked 50 or 60% of the time, that would be easy. We'd say, no, you don't need surgery. We've got this pill. Here, take this prescription. But sometimes we don't have a good alternative, and that drives surgeons towards surgery. Because they see not treating people as failure.
Yeah, or not living up to their oath of trying to help people, or their responsibility.
And their expectations as well. And I think that's a mistake. You can still care for people, and you can still have patients that improve through natural history or other reasons, and not actually do anything to them. And I do this in my clinical practice. I say to people, look, I know you've got pain in your knee now. I'm happy with the scans that you've got a bit of arthritis, but it's not very bad. And we know that this condition fluctuates a lot. And my prediction is that your condition will improve. You may always have some pain, but it won't be as bad as it is now. And you don't need to have treatment. You just need to be patient and wait for it to get better. And if it doesn't get better, don't worry, because you can come back and see me and we can talk about it again. And if you explain to people a little bit better about how things work and how they might improve anyway, and it's not necessarily a good idea to rush in and have surgery because that's got its own complications and it might not be effective, they can be accepting of that.
It sounds like a really good step towards something better, better care and treatment
It's better than
of
saying
pain. Yeah.
surgery doesn't. I can't help you with surgery, so get out of my room.
But I find when I hear you talk that you do say to patients that, this osteoarthritis is your problem. It's not a big problem, but it is your problem. Doesn't that, isn't that overreaching somewhat? Because I'm actually, if I was your patient and you told me that, I'd be reassured, but I still believe that something is wrong with my knee.
Yeah.
Can you see
Yeah,
my
it's
point of
difficult,
view?
and that's the same. It's the same problem with back pain. Is this argument about whether we should be still giving them a label or giving them a condition that they walk away with?
Is it helping them?
Yeah,
I think it's validating them.
Yeah,
and their pain.
The thing is, it's helping them in one regard because it's giving them an answer, and people want an answer.
They want to, that's the thing that's wrong. That's why I hurt.
Yeah, and so in one regard we can say, okay, you've got degenerative disease in the back, but it's okay, don't worry about it. You're not going to end up in a wheelchair.
I'm already worrying about it because you said I have degenerative disease.
Exactly, and this is the argument. And so some people say we shouldn't be saying that. We shouldn't be saying that the degenerative disease is causing your pain. We should just be saying you have pain in the back and it's very common.
Yeah.
And people get it all the time.
I'm questioning, is it actually a disease? Because if we look at scans and we look at scans through age, so the older you get, the more of these changes you get. Does that mean that aging is a disease, or is it just a age-related tissue change?
Yeah, it's an age-related tissue change.
So why do we call it a disease?
Yeah, we shouldn't. Yeah, and we're labelling more and more of these conditions as diseases. The new condition of sarcopenia and other things are classic examples. And and some surgeons some doctors use that example when people complain about their back. They say you've just got grey hair. It's the grey hair of the back. It's the wrinkles. They don't hurt. It's just something that happens to you. It's a natural phenomenon.
For me, at least, that would be less frightening to know. Well, there are changes in your back, but that's what we see is the normal changes like wrinkles and gray hair. Yeah. You cannot not have them. Yeah. Everyone your age has them. You're actually perfect. Yeah. You're perfect the way you are. Yeah. So that's nice to know, but it still doesn't really explain why they have pain. No. So they can still worry about that.
That's right. And often they'll still chase a firmer diagnosis. Yeah. And sometimes explaining to people, I've had this with patients who are very anxious and have been to many different doctors and have tried different treatments, are still chasing the pinpoint cause, the visible, mechanical,
the touchable,
something tangible thing that is causing their pain, so that thing can be extracted from their body.
Exactly.
And their pain
being free. So it's like
I have to explain to them that looking for a diagnosis and having further scans might actually be counterproductive. And sometimes it's better to not have an answer. That's a very difficult discussion to have, though, with patients.
Yeah. I think we need to provide them with better answers, but that demands that we as healthcare professionals need to understand pain better, so we can actually provide them with an answer that reassures them and excludes anything dangerous. Yeah. But they need to have a tangible understanding that validates their experience. Yes. Otherwise, they will be on search for what is wrong with me. Yeah. Is this dangerous? Yeah. Will I die from this? Will I end in a wheelchair? Yeah. So it's just normal to worry about, and especially in a society where we over-medicalize things. Like every time you have some kind of pain, you need to see
a doctor.
You see a doctor or a physio or anything.
You
need to do it now.
All your friends and relatives think they're helping you by saying, you shouldn't be doing anything. You should go and see a doctor.
Go lie down until, I mean, it's really unhelpful, but it is the society we created, all of us, and we need to change these beliefs and understanding of pain, but it's really difficult.
Yeah, and it's not going to happen overnight. We didn't get here overnight. Unfortunately. We're not going to get out of here overnight. No. Yeah.
So I know you do. No, actually, I have another question. What were the responses you got from your book?
Very positive. Yeah, I got a lot of positive responses. a lot of emails and letters and people saying to me that they agreed and it's a good book. So I would say to my face, it has been
positive,
largely positive.
Yeah.
But I do hear stories that perhaps some people are less happy with it. But no, it's been fairly positive because I don't think anything I say in the book is
unjustified.
Wrong. Yeah, I just give examples of things that don't work
and back it up with evidence.
Yeah. So I think it's hard to argue with. I don't know. Maybe there's some mistakes, or maybe things will later be proven to be that I was wrong. I don't know. But largely the message is that we as a society and as individual practitioners overestimate the benefit of what we do. We think that what we do is great, and even when it is effective, it's not nearly as effective as we think it is.
I think that's across all of healthcare, actually, not just surgery. I think physiotherapy, chiropractics, and everything else.
So 80% of doctors think that they're better than average.
Isn't that funny?
Yeah.
So 80% think they're better than average.
Yeah, but it's not confined to medicine. 80% of drivers think that they're better than average. And
I sometimes ask when I teach, who here believes they are at the bottom half of whatever profession you're in?
Yeah.
No one raises their hand.
Yeah.
But that's just funny, right? Yeah. Statistically, someone has got to be, in the worst part. But yeah. All right. I know you do surgery yourself. What kind of surgery do you do? And do you think there's good evidence to support your practice?
Yeah, so my main area of interest is trauma surgery, so fractures, fixing broken bones. That's what I've always done. And I think what drove me into that area in the first place is because it's a simplistic, mechanistic. The bone is broken. I put the two halves together. It's very appealing.
Yeah.
But what surprised me is even there, I couldn't escape these problems where a lot of what we do in fracture surgery is not well supported, or there is now evidence that we should not be doing so much. And there are examples where even fracture surgery is overdone, and there are debates now about what we should be doing.
Do you have a practical example of that?
Yeah, a really good example is a very common fracture, which is fractures of the shoulder or the neck of the humerus, the upper end of the humerus. These are extremely common fractures, particularly in older patients with osteoporosis. And they're commonly treated surgically if they're displaced or out of place. And I grew up treating these surgically. But all of the best evidence we have, multiple trials over the last 30 years, have all shown us that surgery is not better than leaving them completely alone and doing nothing to them and just letting them heal on their own. Even though the x-rays look terrible, they're not any better off. The complications are higher if you operate,
really?
But the results aren't any better. And it's been an interesting exercise because I have been aware of this literature from when I started. I thought, what are we doing here? Why are we operating on these? Then more studies came out and more studies came out. And then recently, a few years back, a very large study from the UK came out showing that surgery was no better than non-operative treatment for this fracture for all ages, not just old people. And the reaction to that paper was a very negative reaction. And surgeons are saying, but they're not very good surgeons, or it's not applicable to my patients, and they try and find a flaw in that study, and so they say, therefore because I can find a flaw in that study is not true.
Applicable to my practice.
Exactly, and not only will I not believe what that study found, I'm now going to continue to believe the exact opposite, which doesn't make any logical sense at all, because there's nothing to support the opposite. Right. And they don't realise this study does not stand in isolation. It was a high-profile study published, I think, in The Lancet or JAMA, and it gained a lot of attention, and so they attacked it. They don't realise that every other study done before it shows exactly the same thing.
I can't help myself. My brain keeps asking the same question. Why doesn't it work? It needs to work. It makes completely sense to me that it works better than leaving it alone. And I still feel that
it's very attractive.
Right now. Yeah. It doesn't make sense to me. That's gotta be one of the instances where you can say surgery will work 100%. I'll bet my life on it, almost.
But you don't realise, particularly in older patients, that the surgery often fails because the bone is very soft. So the screws fall out. It comes apart. There's complications from doing the surgery, infection, damaging structures and things like that you don't get. So it's not as simple as, just thinking I'll put the pieces back together like a jigsaw. Because normally you don't put them back together the way they were. You can't get them good. You can't hold them once you do and they fall apart again. You cause damage by doing that surgery. There's more likely that they'll need to have further surgery down the track because of things that are going wrong with the implants that you put in. And when you think about it, when you don't do surgery at all, the fracture still heals anyway. The X-ray just doesn't look as good.
Doesn't sit well with me. But we got to move on to the next question. Are you familiar with any kind of treatment that is superior to all other treatments when we're talking about pain? Is there one treatment that says that one is just much better than anything else?
No, not really. And it goes back to what you were saying before, is we need to understand pain better. I don't understand pain. I don't understand pain very well at all. I don't even know how knee replacements work. So, no, it's an area where there isn't one thing that is guaranteed to work for pain.
Yeah. So that's my understanding of the field as well, that if we look at treatments for pain, it doesn't seem that there's this specific treatment that's just much better than anything else. Surgery in some cases seems to outperform conservative treatment on the short run. But if we look at 2 years later, it's the same.
Exactly. It's like, so surgery for an acute disc prolapse has been shown to relieve pain very well. And even better than non-operative treatment immediately. But 2 years later, everyone's the same. So, so there's some evidence there, but is it worth it? I don't know.
There's some risk involved as well. All right. Do you have any advice to people living with chronic pain?
I don't know if it's good advice, but when I see patients who have chronic pain, I try to get them to understand that pain is complex. It's a difficult discussion, again, to have, but I try and get them away from this simplistic notion that they're often still chasing the simple thing that can cure their pain forever. And I explain to them, when they've had pain for a long time, their brain changes.
Nervous system changes.
Things change, and it's not easy to reverse that. Pain is very complicated, and it's influenced by a lot of other factors, like the way we feel about ourselves and about the pain, and
our beliefs, our expectations,
chasing a surgical cure for something like that normally doesn't work. And so I try to start the conversation that pain is more complex, and then sometimes I'll refer them to people who are experts in this area. But I have to be careful there as well, because I don't want to refer them to some chronic pain specialists who will give them procedures and injections and opioids forever. And these are not good answers either.
Well, at least opioids, there's absolutely zero evidence to support use
for chronic pain. Chronic non-cancer pain.
There's only side effects and risk of death. That's what you get, and more pain. Actually, so that's what you can get from taking opioids. So that's probably a bad option. So the very final question: if you could change one thing in the pain universe, what would that be? If you could say, I'd change this thing, what would that be?
Can I stick to surgery? Because I think
that's your expertise.
Area. I think we need to change the bar for which surgery gets introduced.
And how it gets
gets back to our very first question, is that we should not be able to introduce new surgical procedures, particularly for pain, unless we satisfy quite a good evidentiary level of a high-quality comparative trial, comparing it to either placebo or something something well structured. That's the thing I would do, because what I see time and time again is people develop these procedures that they think are great, and they just start doing them, without this kind of evidence.
And perhaps they are great, but before we really
don't know. Unless you test it.
There's a lot of dangers in just introducing them.
Yeah. I mean, unless we test it, we don't know. We don't know if they're wrong, but we don't know if they're right.
No,
we don't know either way.
We're guessing.
Yeah.
And that's not really fair to anyone, actually.
Yeah.
Excellent. If I wanted to follow you, or someone else wanted to follow you out there and listening, where can we find you? Do you have an email? Do you have a blog still? What?
Yeah. So I still have a blog, but I haven't added to it for a while. It's still sitting there. It's Dr. Skeptic.
Yeah.
DRSKEPTIC. And I'm Dr. Skeptic. I think so. I don't know. You'll find it. If you type in Dr. Skeptic, it'll come up.
I will find it and put it in the show notes.
And on Twitter, it's Dr. Skeptic.
Yeah.
But the handle is @Dr. Doubter.
Dr. what?
Doubter, DOUBTER.
Oh.
Yeah, DOCTOR.
Yeah.
Doubter. Yeah, as in doubting doctors.
Yeah. Okay. Doubting yourself.
Yeah.
It's actually pretty wise to doubt yourself.
Yeah.
Thank you so much for your
okay, my pleasure. It's been good.
Cool.
Okay. Thanks.
Excellent.
That was good. That was a very pleasant discussion.